Hi there. My name is Vijay Daniels, and I'm the Associate Program Director for Assessment for the Core Internal Medicine Residency Program. I put this video together to help our residents understand how to perform in an oral exam scenario. Hi, Dr. Daprideau. So it's weight loss, is that right?
Yes.
So do I just start?
Ideally, just take 2 minutes to gather your thoughts, and then you can start asking me questions.
Okay. Okay, no, I think I'm good. So when did the weight loss start?
It started 3 months ago.
Okay, 3 months ago. And how much weight?
20 pounds.
20 pounds. Okay, so 20-pound weight loss. Anything else with the weight loss?
Such.
Like any new symptoms?
She felt very fatigued.
Fatigued. Okay. Okay, so fatigued and weight loss. Was there any night sweats?
No.
Okay, so no night sweats or chills or fevers?
No.
Okay. Okay. Weight loss. Does the patient have cancer?
Not that we are aware of. She
so
doesn't
no
know
cancer.
about that.
Okay. And sorry, how old was the patient?
She's 30.
30. Okay. She's young. Okay. So weight loss. Okay. So we said it's been 3 months. She's lost 20 pounds. Was she trying to lose weight?
No, it's unintentional.
Okay, unintentional. Okay, that's good to know.
No.
I had a chance to look over the stem, so it sounds like I have a 30-year-old woman with weight loss. Do I just begin, or?
Just take your time to gather your thoughts, and
Okay.
you can start asking me questions afterwards.
Okay. So, like, I should write a differential down first before we begin?
Yes.
Okay. Okay. Okay, I think I can begin. Is that okay?
Yeah.
All right. So we have a 30-year-old woman presenting with weight loss. My first approach is to clarify the actual weight loss. So, how long has it been, over what period she's lost weight, what amount of weight, and specifically, is there any intentional weight loss?
So she has unintentional weight loss, 20 pounds, over the last few months.
Okay. Few months.
Yes.
Okay, so unintentional 20 pounds. And she knows it's 20 pounds because she's actually weighed herself?
Yes. She
Okay.
had
Okay.
a normal BMI before, and now she's on the low range.
Okay, but definitely unintentional.
Yes.
Okay. All right, so that's helpful. So in terms of my approach, that kind of clarifies the how much weight loss over what period. It's not intentional. So she's 30 years old. So with my differential, I'm going to start just with cancers. Specifically, has she ever been known to have cancer? Has she had regular pap smears if she's sexually active? Is there any family history of premature cancers? Any B symptoms, thinking of like hematologic malignancies that can happen in younger people? Does she smoke would be the other question I'd ask.
So she denies any symptoms such fevers, night sweats, or new bumps or lumps. In terms of the pap smear, she's getting that regularly, although she hasn't been sexually active for a few years. In her family history, the only thing, her sister has diabetes, but she doesn't describe any other cancers. And I think she's not a smoker.
Okay, so it doesn't sound like cancer is high. Sister has diabetes, I'll come back to that. So next thing, chronic infections as a cause of weight loss. So specifically in younger patient, HIV risk factors, we talked a bit about the sexual history, but I have to ask, IV drug use. I mean, she wouldn't have had blood transfusions. She was too young to have blood transfusions before we screened, so that's unlikely. For Hep B and C, again, has she had, I said IV drug use, sexual activity we talked about. Has she ever been vaccinated for hepatitis? Other things that could cause is viral illness, any recent viral illnesses. I mean, it's going to be more chronic, so I think that's less likely. tuberculosis. Has she ever been anywhere where it's endemic with TB? We talked about those symptoms, but especially any hemoptysis or anything like that.
So she had few sexual partners in the past, but she's not known to have HIV. In fact, she's donating blood regularly,
Okay.
and she's HIV negative.
Okay.
There is no use of recreational street drugs, particularly in an IV form, and there is no significant travel history. She also doesn't have any TB risk factors.
Okay. So it sounds like that's lowered down. I should ask, any recent medications that was started around the time of the weight loss?
No, she's only on the combined OCP.
And that hasn't changed or anything like that. Okay, so moving on, less common, but rheumatologic. Okay, so it sounds like we don't have cancer as a cause, infections as a cause, or connective tissue disease as a cause, no medications, it's intentional. So there was a family history of diabetes, so of course, I should have asked earlier, any polydipsia, polyuria recently in terms of endocrine causes, other causes of weight loss. Sorry, was the sister type 1 diabetes?
Yes.
Okay, so in terms of autoimmune, things like she could have is adrenal insufficiency, so she had any postural hypotension, any salt cravings, any increase, like people saying she's tanned, and then other things that are autoimmune, thyroid disorders, well, it's usually hyperthyroid, but in terms of all the hyperthyroid symptoms, has she noticed any sort of anxiety, palpitations, heat intolerance, moist, warm skin, and then finally lower down, but celiac disease, there can be some overlap. Has she noticed any problems with indigestion when she eats or any bowel changes?
Yeah, so thank you for asking all these things. So basically, she doesn't notice any symptoms such as hyperthyroidism. She doesn't have polyuria, polydipsia. She, however, feels dizzy when she stands up, and she's craving salty foods. And a few of her friends recently commented that she looks tanned. They asked her if she went for a vacation or so.
Okay, I think we have. And sorry, the celiac questions, indigestion, that stuff?
No, she doesn't have any diarrhea. She doesn't have any steatorrhea. She's not nauseated, and she doesn't have any vomiting.
And the thyroid, any of those hyperthyroidism?
No symptoms to suggest hyperthyroidism.
Okay, well, I think I have a pretty good idea what's going on. I'll now move on to the rest of my usual history in case I missed anything. So in terms of past medical history, keep your questions very specific. Not like when you take a history from a patient. Don't ask open-ended questions like you would with a real patient, but instead ask very specific questions. Is there any orthopnea? Is there any P&D? Feel free to clarify if you're not understanding what the examiner is saying to you. Then a useful tip is to frequently restate what you know so far. Right at the beginning to restate the case, or if you're partway through and you're a bit stumped, kind of summarize your findings and do that frequently. At the end of the history, at the end of the physical, it works well to allow the examiner to understand your thought pattern. The next thing is when you ask questions, don't ask just one at a time and don't ask all of them at once. But instead, a middle ground is to group your questions based on your differential and use labeling techniques such as, with respect to symptoms of hyperthyroidism, I would want to know. That can help the examiner follow your train of thought and also helps them remember the questions you've asked after you've asked a set of questions. Finally, it is okay to think aloud. Part of the oral exam is to really get a sense of what your cognitive processes are doing. Hopefully that was helpful. If you have any questions or concerns or would like anything clarified, please email me at vdaniels@ualberta.ca.